welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
So our first speaker today is Duncan, a PGY2 EM resident at ECU Health, who will be presenting on epinephrine nasal spray and how it improves allergic symptoms in patients undergoing oral food challenge.
So just a little bit of background. Anaphylaxis, we know, is a rapid onset, potentially life-threatening allergic reaction. Epinephrine is the gold standard first-line therapy. We also know that some people are afraid of needles and fear of injections or delays in the auto-injector use, where they're known as recognized barriers. And Neffy, which is a needle-free epinephrine nasal spray, was developed to help reduce those barriers to help encourage rapid treatment of the anaphylaxis. I had a thought when I first saw this published article of how does epinephrine nasal spray compare to intramuscular just in terms of a PK/PD profile. So there's actually pretty extensive evidence showing that the PK/PD of intranasal epinephrine is fairly equivalent to the intramuscular administration form. So here is a trial from 23, just briefly, that kind of shows the Cmax and Tmax of both Neffy 2 milligrams, epinephrine IM injection, and the EpiPen. And you can see that Neffy really sits in between the EpiPen and manual IM injection in terms of its concentration max and time to max concentration. So just kind of sits nestled in between the two of those. And so it's not something that we should look at and think that it's going to have a vastly different effect based on the PK/PD profile. So jumping into this study, it was made to assess Neffy's efficacy for the treatment of an oral food challenge to see if these induced anaphylaxis symptoms can be treated in a pediatric population. So it is a phase 3 open label single dose study that consisted of a screening period, and then they proceeded into the open label treatment period. And it was done at a single center in Sagamihara National Hospital in Sagamihara, Japan. The outcomes, primary outcome was the change from baseline and main symptoms, or the improvement rate, at 15 minutes, or the final assessment before treatment until 15 minutes after dosing. So it sounds a little complicated. Essentially what it means is they were looking at, after they gave the Neffy, how much did their symptoms improve in that 15-minute span? And if they did not improve and they progressed to secondary treatment, which is standard of care IM Epi, how much did their symptoms then improve in a 15-minute span after that? For their secondary objectives, they looked at the proportion of patients who did not require additional treatment, as well as the grade of symptoms in each organ system and the time to resolution of all organ symptoms. And for their safety, they looked at adverse events, vital signs, and EKG changes. So their criteria for inclusion, they included patients that were 4 to 55 years old. I said earlier this was a pediatric trial. It ended up being a pediatric trial just because they did not include anyone above the age of 17 just by chance. But the trial was designed to include those patients from the start. So they could have had patients up to 55. For their weight, they had to be at least 15 kilograms or more, and they had to have grade 2 or higher allergic symptoms. So those grade 2 or higher symptoms are gastrointestinal, respiratory, or cardiovascular, but we'll get into more of exactly what those mean in a moment. For the exclusion, if the PI or the sub-PI thought that these patients had any history of clinically significant conditions that could confound their results, they were excluded. It's a very subjective measure, but they didn't go into much detail on what these things were that the PI thought could be confounding. So we don't really know that much about what these symptoms or other conditions could be. And then as well as nasal conditions that could interfere with the nasal spray administration. So this could be maybe a nasal polyp or just anatomy that didn't allow for administration. And then the use of any other nasal drugs within 14 days, which they did not specify what these nasal drugs were. It could have been something as simple as a Flonase, but we don't really know. So for the symptom grading, you can see here, this is actually the chart in the trial or in the publication. So there are skin, gastrointestinal, respiratory tract, cardiovascular, and neurological symptoms, but they only included symptom grades 2 or higher of the GI, respiratory, or cardiovascular system. You can also see that the CV system did not have grade 1 symptoms, so they just jumped straight to grade 2. Could be anything from throat pain, current emesis, to chest tightness, hypotension, or tachycardia. For the patients that were included, their age, again, they were young. They ended up including only younger patients just by chance, really. There were males and females in both groups. It was a fairly small trial, so you can actually see in the 1 milligram group, they only had one male. But then you can also see their food allergies, eggs, milk, peanuts, things that you would expect from a pediatric population. For the intervention, they were looking at the onset of grade 2 symptoms during the oral food challenge. So once a patient got the food that they were allergic to and they presented with anaphylactic symptoms up to those grade 2 criteria, the neffy was then administered based on a weight-based dose. So if they were 15 to 30 kilograms, they would get a 1 milligram dose. And if they were greater than 30 kilograms, they would get a 2 milligram dose. Patients were monitored for symptom progression and resolution at the 5, 10, 15, 20, so on and so forth minute mark, all the way up till 120 minutes after the neffy administration. And then if symptoms escalated or did not resolve, again, they had the intramuscular epinephrine at bedside ready to go to provide that standard of care if the intranasal did not work. For the reaction distribution, these are all the grade 2 reactions, but you can see that in the 1 milligram group, they had gastrointestinal and respiratory reactions only. This is also kind of, you can assume this is the younger group because they weigh less, they're pediatrics, they're probably a little bit younger. And then the neffy 2 milligram group, you do start to see also skin reactions and cardiovascular reactions. And then also you can see the total number of reactions is 18. So they included, if a patient reacted, they counted maybe if they had skin reactions and cardiovascular reactions, they counted them separately. For the outcomes, we'll kind of go through one by one very quickly, but they were looking at, again, the time to resolution to grade 0 in minutes. So really, how long did it take for these symptoms to go from a grade 2 to a grade 0? In the cardiovascular group, it took about 32 minutes, but there was only one patient that had cardiovascular symptoms. So there's not really that many data points to get a good view of how long it would take for the general population. For the GI, there were seven presentations that took about 15 minutes. Again, 15 and a half minutes for respiratory effects, 35 minutes for skin and mucosal, and then total, what we really care about, the median time to symptom resolution was about 16 minutes for all of the groups combined. Here we have a nice colorful chart. On the left, it's kind of charting them at the grade of symptoms over time. So you can see a very quick decline in symptoms once they get the dose for the GI, respiratory, and skin symptoms. So you can see a very steep decline they're progressing quickly. They are improving quickly. On the cardiovascular symptoms, you can kind of see a plateau, but that's something we need to consider is, again, there's no grade 1 cardiovascular system. So you can't see a decline from 2 to 1 to 0 because there is no 1. So it stays level until the symptoms completely resolve. And again, there was only one data point for the cardiovascular symptoms, so we might see more expedient decline if we had other data points. And then on the right side, you can see the neffy 1 milligram charted against the neffy 2 milligram over time on the symptom reduction. And again, they both provide fairly similar symptom reduction fairly quickly. This is weight-based, so it's kind of expected. These patients are getting roughly the same amount of epinephrine per kilo, so it's kind of expected to see a similar result like this. For the outcomes, no patients required a second dose of epinephrine after neffy for the initial resolution of symptoms. One patient did receive procaterol, which is a beta agonist that's available in Japan that is not available here in the US. It was for a grade 2 respiratory symptom 8 minutes after neffy administration. Additional therapy was given to 7 other patients, including antihistamines, that beta agonist procaterol, hydrocortisone, oxygen, and mechanical cooling. They were kind of just throwing stuff at the wall at this point, not because the patients weren't recovering, but I really do believe it's because they were having an anaphylactic reaction and being treated with something that hadn't been really proven to prevent or remediate for that anaphylactic reaction to treat it. And then there was one biphasic reaction recorded at almost 3 hours. So they got the neffy administration, they had initial symptom resolution, and then almost 3 hours later, they had a biphasic reaction where they were given meds as well as a normal saline bolus that did not resolve anything. So they were given intramuscular epinephrine. So that's why I initially say the neffy was efficacious for the initial resolution of symptoms, but the biphasic one kind of threw a wrench in things. For the safety outcomes, they had a tremor in 3 patients. These patients got epinephrine. A tremor is fairly expected. Nasal mucosal erythema in 2 patients. Again, it is a nasal spray, so you could expect something along those lines. For the systolic and diastolic, blood pressure were elevated in all patients, as well as the heart rate. But again, we're giving them epinephrine. So what do we really expect? In the chart down below on the left, you can see they have their systolic blood pressure charted over time. And about 20 minutes before they receive neffy, you can see that it's really at the lowest. When they get neffy, they do see that increase in systolic blood pressure. But it's also worth noting, like, these kids are getting food. They're being fed food that they know they're allergic to. And I have to imagine some of the kids are a little bit nervous that they're going to have an allergic reaction. And not only is that increasing their systolic blood pressure, but then the epi on top of it. So the point is really none of these blood pressure elevations were to a dangerous level, and they did recede over time back to normal values. And you can also see, again, on the right, it's just showing how much the systolic changed at a point in time. So it increased initially and then just kind of peaked and dropped back down to normal. So for a quick analysis, it was a small sample size. There's only 15 patients included in this trial. So it limits the generalizability and statistical power. It was open label with no randomized comparator. Of course, this has ethical concerns if you throw in a randomized comparator in an anaphylactic study. You're also not really going to do a double-blind, double dummy, because you're not going to want to delay the initiation of the med that could be life-saving just to give them a second double-blind med. It was only done in the pediatric age group, which, again, this trial was designed to be in peds and in adults. They just did not enroll any adults. And it was conducted in a very controlled setting. So these patients had an allergic reaction, and possibly the best place to have an allergic reaction in the doctor's office or in a clinic. And it might not reflect real world reaction or response to an anaphylactic event out in the public. And it also addressed only up to grade 2 symptoms or grade 3 symptoms that are more severe that neffy may or may not have good efficacy for. So then the key takeaways: neffy successfully resolved moderate allergic symptoms in patients with an induced anaphylactic reaction from an oral food challenge. Median resolution time suggests a relatively prompt action. The observed adverse effects were mild and consistent with known epinephrine effects. And then finally, hopefully the needle-free delivery could reduce barriers to epinephrine use in emergency situations. So with that, I appreciate you guys for listening to me talk about some intranasal epi. Thank you, and I'll open the floor to questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.